to this webinar on the impact of COVID-19 on respiratory care. My name is Eammon Costello. I'm the CEO of patientMpower. patientMpower is a leading provider of digital care solutions, empowering healthcare professionals to manage patients in their own home. I'm delighted to welcome our speakers today, Professor Gisli Jenkins, who is the Margaret Turner Warwick Chair of Thoracic Medicine at Imperial College London. Gisli will present on characterising post-COVID lung injury. Dr. Cillian Hurley, the Associate Professor at the Royal College of Surgeons in Ireland and consultant in respiratory medicine at Beaumont Hospital. Cillian will present on models of care for COVID recovery. And Colin Edwards, who's Chief Scientific Officer at patientMpower, and he will examine the understanding of long-term impact of COVID-19 using patient-reported outcome data and outcomes. Please submit any questions you have throughout the webinar. We'll have a Q&A session after the presentations, and you should see a Q&A button at the bottom right-hand corner of your screen. With that, I'd like to pass over to our first speaker, Professor Gisli Jenkins.
So thank you, Eammon, for that introduction, and I hope everyone can see my slides. I'm going to be characterizing post-COVID lung injury. So these are my disclosures. Just to note, I obviously have a number of disclosures, including work I am doing with patientMpower. So what I'm going to talk about in the next 20 to 25 minutes are to try and address three questions. One is, what is COVID-19? And most of you will know everything there is to know about that. And then the two questions which are really trying to predict the future, which is, will COVID-19 cause pulmonary fibrosis? And if it does, can we prevent the development of post-COVID fibrosis? And without giving the game away, we don't really know the answers to either of those two questions just yet. So COVID-19 is caused by infection with the SARS-CoV-2 virus. And at the current time, there are almost 150 million cases and almost 3 million deaths worldwide. And we know that the risk factors for increasing severity of COVID-19 include increasing age, male sex, and comorbidities such as hypertension, type 2 diabetes, and ischemic heart disease. And that's what really piqued my interest when this became apparent, because these are similar risk factors to the development of idiopathic pulmonary fibrosis. And the sort of pathobiology related to COVID-19 is now fairly well established, and I'll describe that in coming slides. And the time course of events is now fairly predictable. So the virus binds the ACE2 receptor, which is predominantly found in the upper airways and nasopharynx and ocular epithelium. And then over the next 5 days, this incubates and replicates and transmits around the body. And then after 5 to 10 days, people will suffer from cough, fever, and various degrees of hypoxia, if they're symptomatic at all. And then after 10 days, there's the high risk period for ARDS, which occurs in about 20% of cases. And then following ARDS is the peak period for risk of death, which is between 2 and 3 weeks. And then it's after that time that the risk of ILD increases. And you can see that in these slides here. So, whoops. So this is a time series of a patient courtesy of Kate Poynton. And what you can see is at 21 days, there is marked ground glass shadowing with some traction, and there is some restriction as seen by the small lungs. And then 6 weeks later, the ground glass is largely resolving and the traction is getting worse with progressive fibrosis. And I think it's now agreed that there are at least 2 phenotypes of COVID-induced ARDS, probably more. But broadly speaking, you can get direct viral injury to the epithelium. This is shown on these set of panels here. So this is RNA scope What you see is the staining here is infected epithelium within the lung, and you can see there are large quantities of infected epithelium, and this is mirrored by the serous red staining, which demonstrates collagen, and here we have integrin staining, and this is reflective of injury in the epithelium. Whereas in this set of panels, also taken from post-mortem from a patient who died of COVID-19, you can see there is virtually no evidence of viral RNA in this section of lung. And we looked everywhere, and actually for the majority of post-mortems we've looked at, you see very little viral RNA. Despite this, you got large amounts of inflammation and thick bundles of collagen, in fact, more so than with the direct viral injury. And again, you see large amounts of beta-6 integrin staining, but here we see the epithelium is sloughed off into the middle of the alveoli. So the patterns are quite different. And I think it's now emerging that you have a direct viral injury, and this is more of an immune-mediated injury, which could be important in characterizing post-COVID ILD. So will COVID-19 lead to pulmonary fibrosis? Well, we know that polymorphisms that predict the risk of pulmonary fibrosis, such as DPP9, are associated with severe COVID. And these are data from the Genomic Consortium published in Nature last month. And DPP9 was one of 3 genes which was found to associate with severe COVID. If we look specifically at other fibrosis-related genes, we get a slightly different story. And this is interesting, but it's difficult to fully explain at the moment. And these are data that we published in a Mendelian randomization of fibrotic genes and severe COVID. And what we found is that MUC5B, and others have also found this, is protective against severe disease. So there's protection against the general population of getting symptomatic COVID. The increases in terms of the odds ratio increases in protectivity, if that's a word, for hospitalization. And then for very severe disease and death, the effect is even more pronounced. Interestingly, however, this is unique to MUC5B. So all other fibrosis genes, and there are between 15 and 17 that we looked at, increased the risk of severity. So the presence of every other fibrosis gene, and you can see here by this is a take one out analysis. So you put in all the genes and then you look at the risk of severe COVID with these fibrosis genes. And if you take one out, it doesn't make any difference until you take MUC5B out, and then the genes show high significance for severity. So the genetics are complicated. MUC5B is different, but there is definitely an association between fibrosis and severe COVID. So what about post-COVID and post-COVID lung function? And there's quite a lot of emerging data now, and these are some of the early data. And basically what this shows is that 1 month following COVID infection, you do see a reduction in your gas transfer and a reduction in your lung volumes in a large proportion of the population. And this increases with increasing severity of pneumonia. In data from Canada, a similar effect was observed at 3 months. Again, there is a slight reduction in FVC, a more profound reduction in gas transfer. And in this study, they actually looked at CT scanning. And when they looked at inflammation and reticulation as a marker of fibrosis, they saw considerable amounts of interstitial lung disease 3 months following COVID. And if you combine the inflammation and the scarring, 80% of patients had, at 3 months, had some evidence of interstitial lung disease. It was more inflammatory than fibrotic, but there was still a lot present. So should this surprise us that that SARS SARS-CoV-2 can promote pulmonary fibrosis? Well, if we look at viral infections generally, we see a similar picture. So this is a systematic review done by Lara Fabry, a clinical fellow in my lab. What she did was to look at all the radiology and lung function that had been published on SARS-CoV-2, SARS, MERS, and influenza. And unsurprisingly, there's a huge amount of literature on SARS-CoV-2, and maybe more of a surprise, there's less of a literature on influenza. But what you can see is that there is about 25 to 30% of patients have evidence of inflammation on CT scan if you have SARS-CoV-2 or influenza. This is even higher if you have SARS. Similar numbers are also observed when you look at the fibrotic components. And it's important to be aware that we were not looking at the scans, just at the reported data from the studies. And if you look at the time series, what we see is that at baseline, the amount of inflammation you see on a CT scan is 75% for COVID, which is not a huge surprise. I mean, it's COVID pneumonitis is what takes you into hospital. If you have a CT scan, you're likely to see some evidence of inflammation. And it does resolve over time, but it doesn't resolve certainly at 6 months to baseline. And you're still getting almost 40% of the inflammatory changes observed at 6 months. The fibrotic changes are interesting. So what was observed was that about 25% of scans on initial scan at baseline, so this was the first scan that the patient had, showed evidence of fibrosis. Unlike the inflammatory change, this didn't change much over time. So if you have fibrosis on your baseline scan, it is still there at 6 months later. And a similar finding was observed in lung function. So if you had restricted lung function, so about 25% of patients had reduced FVC, and it didn't change much with SARS-CoV-2 or influenza. Almost half patients had a reduced gas transfer. Again, showing what others have shown in COVID recently is that the gas transfer is reduced far more commonly than the FVC, indicative of perfusion defects. And unlike the inflammatory change on a CT scan, the lung function stays the same. So maybe it's more affected by fibrosis. So if you see reduced lung function at baseline or 1 month, it tends to be of a similar level 6 months later. What Lara then did was to see if this was an effect of ventilation, and certainly it did appear that if you had mechanical ventilation, there was evidence of inflammation. Again, this resolved over time with CT scanning, but the fibrosis was also worse if you had ventilation, and it not so bad if you were not ventilated. So it does appear that some of the fibrotic consequence that is observed is due to ventilation. However, these effects were not observed in terms of functional consequences. So it didn't appear that ventilation was affecting the gas transfer. It was more affecting the fibrosis seen on CT. But these were all a collection of studies assessed at different times. So this, although we get some estimate of what happens over time, no one has followed all these patients over a year. or better still, longer. So as part of the FOSP COVID platform, the Fibrosis Working Group set up the UK Interstitial Lung Disease post-COVID study. And the aim of this study is to follow up patients for 12 months with lung function and imaging, including xenon MRI, and also in some cases with bronchoscopy and lavage, to actually determine what happens over time and what the effect of severity is. So the assumption is that more severe disease will lead to more severe fibrosis, which will be a consequence both of the severity of the injury related to the underlying risk factors and also the treatment. The UK Long COVID ILD Consortium is a national affair, and as you can see that these are all the collaborators, and so we thank everyone for their participation, and I think this will give us some real insights into what the consequence of COVID is on interstitial lung disease going forward. So can we prevent the development of post-COVID ILD? Well, the obvious way to prevent post-COVID ILD is to prevent COVID in the first place, and vaccination will clearly make an impact there. But we've also seen with the recovery study that dexamethasone reduces severity and saves lives, which is consistent with the observation that there is an immune and inflammatory mediated pneumonitis. So the obvious question to a lot of us is, well, will this reduce the development of interstitial lung disease? And we're certainly seeing some patients with interstitial lung disease after their 10 days of dexamethasone. So the next question is, should we be giving longer courses of steroids to patients who have post-COVID ILD? And the answer is, we just don't know. So those are studies waiting to happen. The FOSP COVID study will give us some idea because it will help us understand the degree of ILD in patients who've received dexamethasone as part of the recovery study, but it'll be observational rather than interventional. The other drug that has been shown to reduce the risk of mortality post-COVID or as a result of COVID is tocilizumab, and this is a systematic review done by Fazil Khan, another clinical fellow in my group. And this included all the retrospective and prospective studies which assessed tocilizumab for acute COVID, with the exception of recovery, because this was published a couple of weeks before we had the recovery data. And what you see is that there was a significant reduction in risk of mortality with tocilizumab at about 80% mortality compared with non-tocilizumab, which is pretty much what the recovery study showed. And as you all know, tocilizumab is an anti-IL-6 monoclonal antibody, suggesting that IL-6 might be an important mediator of both the acute pneumonitis, but will it have effects beyond the acute pneumonitis on post-COVID ILD? And certainly, IL-6 is known to be quite a pro-fibrotic cytokine, and animal models have shown that you can inhibit IL-6 if you administer anti-IL-6 therapy at the onset of the fibrotic phase of the bleomycin model, so here at 10 days. However, what they found was if they administered the anti-IL-6 therapy at the time of acute lung injury administered by bleomycin, they actually got worse fibrosis subsequently. So I think it's too early to say that tocilizumab will reduce post-COVID ILD. It's certainly beneficial in patients with acute COVID, but it will be intriguing to see what the long-term consequences are. So what about other antifibrotic drugs? So this is a review I published with Pete George and Athol Wells last year, which shows that a number of the currently available antifibrotic therapies, either in development or currently in clinical trials, have the potential for inhibiting viral entry, such as integrins or galectins, or viral replication, such as drugs like CC9001 or the Promedia drug, and the mTOR inhibitors. So how might they work? Well, a number of them, as I said, have been shown to inhibit viral entry or replication. Most of them have been shown to inhibit, in animal models, acute lung injury-induced fibrosis. And if we look at the specific mechanisms, many of them have had inhibitory effects on IL-1, a pro-fibrotic cytokine, and IL-6. So there is rationale, at least, for considering antifibrotic drugs, though clearly they need to be assessed in clinical trials. And I think on that basis, it was one of the reasons we decided to move forward with a platform trial for post-COVID lung disease. Clearly, the recovery trial and the REMAP-CAP trial had led the way in treating acute COVID, and I think it is clear for all to see the benefits of embedding research in clinical practice, and the amazing efforts of the recovery and REMAP-CAP teams to give us drugs such as dexamethasone and tocilizumab, which really do improve survival. But there was nothing in the post-COVID space. And so Charlotte Summers and Mark Toshner got together and in a Herculean effort got this submitted and funded, and is now recruiting to assess drugs for readmission and longer term outcomes. And we're optimistic that some form of disease modifying anti-inflammatory or anti-fibrotic drug will be chosen for this platform. So I'm going to conclude by saying that COVID-19 leads to acute lung injury, which can repair, causing fibrosis. That there are shared genetic risk factors for severe COVID-19 and pulmonary fibrosis. That viral pneumonias generally are pro-fibrotic. SARS more so than COVID-19, and I think it's more pro-fibrotic than flu. But given the scale and the size of the COVID-19 pandemic, remember that about 8% of infections end up in hospital. And given that we've had hundreds of millions of people infected, that's a lot of people in hospital and a lot of people discharged. And therefore, we're likely to have a large amount of post-COVID ILD. The effect of dexamethasone and tocilizumab are likely to be beneficial, but further data are required to understand whether they will affect post-COVID ILD. And given the rationale for a number of antifibrotic medications, a platform trial for long-term complications is now available and important to try and address these problems. So I'd like to acknowledge everyone who helped. Many of them are listed on the UK ILD Consortium, but particularly my team who will be joining me in London. As we've just moved down from Nottingham just over a month ago. So I'll stop there and thank you for your attention.
Thanks very much for that, Gisli, and great to see the Heal COVID platform getting funded to hopefully answer some of the unanswered questions that you raised. A quick reminder to everyone to submit questions through the Q&A button down in the bottom right, so you can ask Gisli kind of any questions. So we'll be hoping to start those in about 35 minutes time. So I'm now delighted to pass things over to Dr. Cillian Hurley.
Great, good afternoon. So I'm just going to try and share my slides here. Okay. So thank you very much to patientMpower for giving me this opportunity to speak today. So I'm going to speak about models of care for post-COVID recovery. Great. So I do work with patientMpower on research studies. So over the next 20 minutes, I'm just going to talk about a patient case that's just going to really describe the severity of illness, and I picked a case that really describes someone with really severe COVID-19 and went to the ICU. I'm going to talk about how we develop a model of care based on best practice, and look at some of our analysis of outcomes at 3 and 12 months, and give you some ideas about my key messages for the future in terms of care models and COVID-19. So like everyone working in a hospital last March, we had to adapt to the situation very quickly. So this is the Irish Army at our hospital putting up some tents for our COVID-19 testing, our drive-through testing, and this is some modifications to our accident emergency. There was great innovation on the wards as well. One of my colleagues developed an app to monitor patients in hospital in terms of severity, so we could keep an eye on large numbers of patients with acute COVID. And also we were able to use the COVID-19 app afterwards to monitor patients when they were discharged. We did use some new methods to bring on non-invasive ventilation, using hoods. And we even tested a scuba diving hood on one of my colleagues, but in fact never used it on any patients, but I have seen some videos of them using those in other centers. So let me talk to you about this patient case. So this patient has agreed for me to discuss this case. So it's a 54-year-old man transferred from an outside hospital, background, high blood pressure, high cholesterol, and psoriasis. He presented with a week of shortness of breath and cough. And he was intubated and ventilated in the emergency room for profound respiratory failure and transferred to Beaumont Hospital. This is his chest x-ray. You can see he's ventilated in this x-ray. And he's got a bilateral peripheral infiltrates consistent with COVID-19. He was diagnosed with acute respiratory distress syndrome, ARDS, based on his x-ray and level of respiratory failure. He initially needed 65% FiO2 or oxygen. He was sedated with 3 agents. He needed a feeding tube, he needed empiric antibiotics, prophylactic anticoagulation. And his SARS-CoV swab was initially negative, but in fact his bronchoalveolar lavage was subsequently positive. He did have hydrocortisone, and this was before, as Gisli mentioned, the RECOVER study. So steroids were not indicated or proven, but he did have steroids for just for 2 days. He was proned as per ARDS protocol, and this is his CT, and I think this might be informative for us. So you can see here ground glass changes, which are peripheral, but also central throughout, going to the bases, and some traction bronchiectasis. And this is just after 2 days in the ICU, and some consolidation at the bases with some bronchiolectasis at the bases too. So this patient had a very stormy course in intensive care. So he was actually in the intensive care for right through April, May, and into July. He had recurrent atrial fibrillation. He had cardioversion and also had amiodarone. He was discovered to have a right coronary artery occlusion. That stenting was required. He had a right upper lobe pulmonary embolism. He had acute kidney impairment and required dialysis. He had profound myopathy and needed physiotherapy while ventilated. He had ventilator-associated pneumonia, the possible fungal lung infection. I'm going to show you some images of that. And he had hypothyroidism, was probably due to his amiodarone for his atrial fibrillation. So this is his CT well into his admission in June. So you can see now much worsening of consolidation. See the endotracheal tube, his trachea. And I see this development of these pneumatoceles with some debris inside. You can also see he's got bilateral pleural effusions and traction bronchiectasis here, and developing low volumes and fibrosis throughout, and another a pneumatocele here at the base and one here. So quite profound inflammatory and fibrotic disease here into the ICU stay. So he was in the ICU right until in the middle of July, then transferred out eventually to the ward, the multidisciplinary rehabilitation, physiotherapy, occupational therapy, speech and language, dietetics, and was discharged to our rehabilitation hospital in August after a long stay and complex stay on the ward. When he was there in his rehabilitation hospital, it was certainly a long road to recovery. He was there from August through until November and required intensive physiotherapy, occupational therapy, speech and language. So he describes, and he gave an interview in the paper at the time in November before he was discharged, that he had to learn to eat and drink and walk, and it was like he was a baby again. So he spent, you know, approximately 5 months in ICU with COVID-19. So the path to recovery at home was also slow. So he remains on 4 liters of oxygen, remains very myopathic, reduced mobility, has had pulmonary function tests, which I'll show you. And this shows that he's got a reduced forced vital capacity of 50% predicted for his age and height. He also has a reduced, profoundly reduced DLCO at 30% predicted. His X-ray, last X-ray showed extensive consolidation when he back in November, and indeed he had a CT scan exactly a year after his admission. I'm just going to show you, walk you through that CT scan now. So you can see the upper lobes. There's some fibrotic changes in bronchiectasis, and there's some movement artifact here, but you can see that there's a reduced lung volumes both sides. And this pneumatocele here that has not healed completely, but you can see the debris is gone, and this other pneumatocele at the base is still there. But in fact, overall, his lungs have recovered quite well, but still some residual fibrotic and bronchiectatic changes that remain. So, so just to describe our experience with COVID-19, and then I'll just describe over that, I'll go on to the models. In the first wave, we had about 400 patients admitted from March through June, 220 with pneumonia and severe respiratory failure requiring oxygen or respiratory support, 32 requiring high flow oxygen or non-invasive ventilation at ward level, and 41 requiring ICU admission for intubation and mechanical ventilation. Interesting gender differences. 3/4 were male. Men spent longer in the intensive care and had higher SOFA scores or organ failure scores. Overall, our mortality was 20%, which compares quite favorably with international rates. Early complications that we were aware of for our patients in the ICU include acute respiratory distress syndrome, pulmonary embolism up to 5% of patients, myocarditis in a smaller number of patients, and the ICU complications that we see for any patient that's intubated and ventilated for a long time: critical care myopathy, prolonged rehabilitation need, tracheostomy, acute kidney injury, and superinfections, all of which our patient, in fact, had. The short-term complications we saw immediately after discharge were ongoing dyspnea, cough, reduced exercise tolerance, thought to be due to deconditioning, concern about pulmonary embolism afterwards, and many patients were readmitted with this after discharge, a new airway disease or ongoing inflammation post-pneumonia or pneumonitis. Readmission occasionally with ongoing temperatures, tachycardia, ongoing muscle weakness and pain were very prominent, and very prominent was severe fatigue, and some of the psychological or psychiatric complications of COVID-19 include low mood, anxiety, psychosis, and cognitive impairment. So this, at the time, through June, July, was a major follow-up challenge for us. So we started to look at different models of care, and also looking back through the literature to see what we could learn from SARS-1, from other ICU patients in literature in terms of ICU stay and people post ARDS and post H1N literature. And the literature suggests that these patients, particularly ICU patients, needed a follow-up in a specialized clinic over 1 year. There were some other models existing. So the BTS, British Thoracic Society, suggested a post-COVID model. Two different models, really. One for those in the ICU setting with a short follow-up, telephone consultation or face-to-face, and then a 12-week more comprehensive follow-up. And then really triaging patients based on their investigations or their continued need for support. And again, thinking about interstitial lung disease, even at that time, considering specialist intervention in an ILD service. Also thinking about pulmonary hypertension, which we really haven't seen a lot of as yet, but I think this early days yet. Other follow-up model then for community with a 12-week post-discharge follow-up. And then step 2 involving pulmonary function tests and really trying to outrule these pulmonary emboli immediately post-discharge. So then we set about setting up a COVID-19 recovery team, and that's really the key here, is getting the right people to deliver this kind of specialized care. So it was truly multidisciplinary. So myself and Imran Suleiman, our ICU colleagues, our infectious diseases colleagues, and also our colleagues from psychiatry and psychology, and our colleagues from rehabilitation and physiotherapy in the hospital and also in our rehabilitation centre in Clontarf. So we developed a pathway largely based upon the British Thoracic Society one. So just in a little bit more detail, we're going to take those patients admitted to the hospital and see them in a virtual way. So do these tests for them, chest x-ray, blood, symptom screen, mental health screen, and a quality of life score. We took the SF-36 quality of life score, as this was used in ARDS research in the past, organized these tests, and then we performed a virtual assessment clinic 8 to 12 weeks afterwards. Those patients that appeared to have problems or had any concern at this MDT, then we brought them back for an in-person clinic at 12 weeks after discharge, where they got a chest x-ray, pulmonary function test, 6-minute walk test, bloods, and a more comprehensive review if needed. Many of those patients needed to follow up at 6 or 12 months in a survivorship clinic. Some needed to go to the mental health service, which includes psychiatry and psychology, and liaise with community services. And others were integrated into the community care with a general practitioner. And we published this multidisciplinary model back in July, really to try and give an indication to our colleagues across the country and also internationally about what would work in terms of a COVID model, a recovery follow-up model of care. So I'd just like to review some of what we found so far from our recovery clinic. And this was compiled by Sheila Tolan, one of our excellent specialist registrars in respiratory medicine. So we performed a single center prospective cohort study, inclusion criteria, SARS-CoV positive PCR or a clinical diagnosis of COVID-19. Admitted to the hospital with pneumonia from March through to May, or a nosocomial infection. And the data included, like I described, those post-COVID symptom questionnaires, mental health, laboratory, and radiology tests. So just to describe the flow of data, consort diagram. So patients, 430 patients swabbed positive, nearly 230 had pneumonia. Of those severe were those patients on the ward. Critical ward were those who required non-invasive ventilation or high flow oxygen, and 41 required ICU care in that time period. Of those, overall, about 20% of patients died in hospital or immediately post discharge. Of those, then we discussed 188 who we discussed at a virtual MDT. And we also had patients that were referred to us from occupational health, a small number. Of those, then we brought 71 back to an in-person COVID-19 recovery clinic. Many were discharged back to the GP and some on to other services. So these are the demographics of those patients. So it's a young age, 60 in mean age in severe, 71 for critical ward, and a younger population in intensive care. Predominantly men, over 60% men in all those groups. There were some nosocomial infections, many nosocomial infections in the severe group. Many patients, again, nearly 5% of patients or 4% of patients had pulmonary embolism, and some had those risk factors for diabetes, respiratory, or risk factors for COVID, including respiratory disease, diabetes, ischemic heart disease, and immunosuppression. And so when we looked at the quality of life scores, the SF-36, difficult really to parse or tease apart those different groups, and we didn't see significant difference between the severe critical ward and ICU groups, but there was some impairment in physical functioning, in social functioning, and also in psychological and general health and pain, particularly in the ICU group. Of interest, when we screened over 100 patients in mental health screener, which we developed, 30% of those in the severe group, 100% of those screened in or 6 out of 6 of those in the critical ward, and nearly half of those in the ICU screened positive for mental health screen and went on for further assessment by our psychological and psychiatric services. Chest X-rays at 3 months, 5% or nearly 5% of the severe still had infiltrates, 14% in the critical ward had still infiltrates, and 10% in the ICU had still infiltrates, with small number of CTs, which we haven't analyzed as such, but certainly all those from the ICU were still abnormal at the 3-month interval. We looked at physiology data, like the data that I just presented. The FSE was reduced more so in the ICU group compared to severe, and also reduced DLCO in both severe and in the ICU group, but still around 80% at the 3-month mark. When we look at the 6-minute walk test at 3 months, there's some interesting data here. Certainly a difference between baseline oxygen, resting heart rate, max heart rate, and also some differences in the maximum oxygen or saturation at 3 months between the severe and the ICU group. No differences in the distance walked, but those numbers belie some big differences in patients individually, particularly in the ICU group. We did bring back that group at 1 year, so just a couple of weeks, so I haven't had a chance to really analyze it in great detail, but just really to notice that there was some reduction in the distance traveled or walked for those in the ICU group, and particularly compared, and now it's difficult to compare these because the occupational health group referred were a younger population, but certainly some interesting findings really that the max heart rate in the ICU group, that's at baseline, was 147, but there was individual in the occupational health group with a max heart rate of 156. The longest distance traveled, or the lowest distance traveled in the ICU group is 180 meters, and they stopped due to cough and chest pain. But interestingly, in the occupational health group, which probably mirror community acquired ICU because these patients were not admitted, the lowest was 150 meters, and they had to stop for cough, chest pain, and shortness of breath. So I've really spoken about the patients that were admitted to the hospital, but of course, many patients didn't get to the hospital or indeed the ICU, and were treated in the community. And less is known about those patients, but we know that those patients that had symptoms for less than 12 weeks, they needed assessment, but it can be normal. But really, I guess the advice here is that if there's severe shortness of breath, chest pain, neurological deficits, that there needs to be some safety netting carried out in the community and special referral if needed. Symptoms greater than 12 weeks, we're really calling a post-COVID-19 syndrome. And an important part of that is really managing comorbidities. We've really diagnosed quite a few patients with new diagnosis of asthma in this patient cohort. And for these patients diagnosed and treated in the community, assessment and treatment in the community is probably most appropriate. Well, that needs access to diagnostics in the community, access to rehabilitation in local hubs. And this may be based on the chronic care model from Sláinte Care, or access to mental health services as well. And there's some nice information which has been published recently in the BMJ, looking at how to manage and triage and care for patients with post-COVID syndrome in the community. So I'd just like to finish by saying we developed a hybrid model based on the best practice that we could find in the literature with virtual and in-person, and we successfully screened a large number of patients with COVID-19 pneumonia from after admission. In this cohort, there's still some impairment, radiology, physiology at 3 months, particularly in the post-ICU cohort. And at 1 year, most were returning to normal, but there were some exceptions to that, as I described with that very severe patient. Patient quality of life scoring is not consistent with the initial severity of illness, and that was included was our SF36 and a mental health screen. And a comprehensive assessment is needed initially, and more long-term follow-up of these ICU patients is necessary, and more work is needed in the community for post-COVID syndrome. So that's all I have to say, and I'd be very happy to take questions at the end. Thank you.
Thanks very much for that, Cillian. Yeah, very sobering seeing that severe patient, the length of ICU stay that they had, and the arduous rehabilitation ahead. As Cillian said, if keep submitting the questions to the Q&A box, so we'll start them hopefully in about 10 minutes. So right now I'd like to pass things over to our final speaker, Colin Edwards.
Just unmute myself, and hopefully you can hear me and see my slides coming up shortly. Can you see my slides? Okay. So good evening, everybody. I'd like to try and really just spend a little bit of time discussing how we can use patient-reported data or patient-reported outcomes to better understand what's happening on the long-term impact of COVID, both for supporting patient care, but also for potentially contributing to research. Are my slides moving?
Not yet.
Okay, now
yeah.
Okay, so I mean, as Gisli and Cillian have already said, the long-term impact of COVID is highly variable. There's now considerable literature showing that there's a big variety of symptoms and severity of symptoms, and also a big variety in the duration of those symptoms with different people. And it's not perhaps fully clear yet how does this differ by pre-existing conditions that the patient may have had before COVID, and also will this change with new variants of the disease or other factors. The other issue is, what is the burden going to be on the healthcare system, because the patients are presenting with many different symptoms to different parts of the healthcare system, and it's not really clear what's the best healthcare environment or the best healthcare speciality to treat those symptoms in those patients. And fairly recently, NICE has published guidelines on managing the long-term effects, and I would imagine these guidelines will evolve quite quickly. The other aspect to this is there are a lot now of patient communities who are greatly affected by long-term symptoms from post-COVID, and they are becoming quite active in conducting their own research. I mean, this is a collaborative which is quite an international collaborative, but there's quite a few people in the UK, I think, who are steering this, and they've regularly doing surveys of patients. The last survey they did was in many countries, many different languages, and their most recent survey was published in December. In patients who only a small proportion of these patients had been hospitalized prior to completing the survey, so only about 8% had been hospitalized. But it's quite interesting, because obviously surveying this number of people, you're going to see a very, very big variety of symptoms. But what's key is that many of the patients were reporting symptoms after 90 days. And the other feature of this survey, which is in line with what's been published elsewhere, is that the most frequent symptoms that were present sometime after COVID were fatigue, post-exercise malaise, and cognitive dysfunction, but a very, very wide range of other symptoms reported, shortness of breath being very common, as we've seen elsewhere. There's some work from St. James's Hospital in Dublin, which is a busy urban hospital in Dublin, and they published recently in Annals of ATS from Liam Townsend, and they offered 480 or so patients outpatient appointment, of which only about 30% of those patients attended. Half of those patients had needed hospitalization, but a lot of those patients did not feel back to full health at about 75 days. And one of the interesting things about that study is they tried to quantify the fatigue in patients using a standardized fatigue score. And about half of the patients that they saw actually would have met the case definition for fatigue. So fatigue is clearly, quite a problem for some time afterwards. And some patients had abnormal X-ray. There's another study recently published from a French group, which was on patients, on all of these patients had been hospitalized prior to the study and were followed up. About half of them were followed up about 4 months after discharge. And again, similar type of symptoms seen to the other studies, but again, a wide range of symptoms. So one of the difficulties that's going to happen, and that is happening, is what symptoms are the ones that are going to require the most treatment? How will they be treated? Who will be delivering it? And how are the patients going to present to be triaged for treatment? So we've been very focused as a company for several years now on working with patient groups and with researchers in capturing patient-reported outcomes and data to support patient care, to support the patient in their own self-care, and also to provide data to support research. So our view is that this collection of symptoms, which will vary from symptoms that are very difficult to measure to other things which may be more amenable to measurement, is that ongoing capture and frequent capture of this kind of data could be very useful in understanding the long-term impact of COVID. And we need to be able to capture a wide variety of symptoms, but also need to be able to customize for an individual patient what is the most important thing to measure for that person, because it is going to be different. Ideally, we would need to pair this with objective measures, if there are objective measures that can indicate what's happening with that individual, and also with appropriate quality of life instruments. Fatigue, if fatigue is the major issue, breathlessness, if breathlessness is the major issue, with the principle of building a picture over time of what's going on with that person. And this can be, put into a form where it's readily available to the patient to do this in the form of an app. And we have a lot of experience of this, and we've been doing this both for a variety of respiratory conditions for some time, and also most recently for the acute follow-up of acute COVID patients. And this could be offered to discharge patients as part of their care. The other aspect is the data could be shareable in real time with the clinical centers, so that prior to follow-up, the data could be reviewed, try to increase understanding of what are the major issues for that person at that time. So our sort of design concept around this, and we would be very keen to work with centers on this, is a customized health diary for patients. There are three key aspects to this. One is to identify the key symptoms, and we're working in ways in which patients could actually choose from a menu of likely symptoms and pick maybe the top 3 that are most troubling for them, so that you have an app that's relevant for that person. The other thing is it has to be easy. we need to also have more discussions with patients about what's actually important to measure from their point of view. It has to be such that it's easy to collect information frequently, so that it becomes something that is a habit and also provides a more richness of data. There are some tools to measure, the more common symptoms such as fatigue. There's some quality of life or instruments that are quite specific that one could measure at appropriate time intervals for the more common things such as anxiety, fatigue. And then a key question that we've heard anecdotally from patients is, can I get back to work, or can I get back to what I usually do? I mean, one key question of how well somebody's feels is, are you back at work full time and it's not exhausting you, or are you back to what you usually do? I mean, we've heard of 15-year-old boys that still can't get back to playing soccer 3 months after they've been infected. It maybe there's some objective data can be useful for some patients, but maybe not. But it's quite simple to track some certain things like activity or steps per day as a proxy for activity. Our existing interstitial lung disease platform is being used by some centres to monitor some patients who have post-COVID pneumonitis, and they're using this approach with home spirometry as well as oximetry. And I think it's because the post acute phase symptoms are so varied. It's kind of going to be an approach where you need to collect lots of different kind of data. It's probably quite dirty and messy data, because there won't be, many patients will be reporting fatigue, but maybe only a small number reporting other symptoms, but those symptoms could be very troubling for that person. So we'll be very keen to work with partners on this, on developing this further and rolling it into care programs or rolling it into research programs to try and track the long-term impacts of COVID, including where patients have definite post-COVID lung disease, adding spirometry to that or other measures of lung function so that we can track those over time. So I'll stop at that point and be happy to take questions on this.
Perfect. Thanks, Colin. So there's lots of Q&A coming through. So we might summarize some of the ones, Gisli and Cillian, that you've already answered in the chat, just for people who'll be getting the recording. So Catherine Gisli was asking about, do we think we'll see forms of progressive fibrosis post-COVID?
So I think it's a difficult one to answer because the timeframes that we're looking at are so short. I think certainly over the first 12 months, the vast majority of people will get better, I think, or if they have fibrosis, it will stay the same. And certainly that would be typical of post-ARDS fibrosis generally. But my greater concern is over the longer time, because we know that the exposure fibrosis relationship is many years. So I suspect that although we might be reassured by what happens over the first 12 months, we need to be vigilant over the next 5, 10, 15, 20 years, because that's when we might see the development of progressive fibrosis based on what we know from other injury response.
Okay. The next one, what therapies will be used in Heal COVID, and do you think long-term therapy years will be required? And there's another one in the chat that's related, just around what is the process for commercial pharma companies joining the Heal COVID platform?
So the Heal COVID platform works very much like the recovery platform. In fact, it's modeled on the same principles, and Martin Landry is a member of both. So the first thing to say is that it's currently available therapies. So I think it's unlikely that any drug which is not licensed for treatment within the NHS at the current time will be chosen for the platform. And the drug choices for the platform are via the CPAG committee. So they they assess therapies for analysis. The first two chosen were apixaban and simvastatin, and then we will see what the committee comes up with going forward. But they will be, currently licensed therapies.
Thanks. So for Gisli, given the genetic variants involved in the disease, what might we learn from the different inflammatory and immune response and presumably the effects of COVID-19 seen in different ethnicities? Could these point to different treatment strategies based on genetic variation?
So I think that's a great question. The answer is I have no idea, but hopefully the UK long COVID ILD study will help address those questions. Those are just the sorts of questions that we're interested in trying to answer. And ultimately, I think stratification is the way forward. I think what we see with recovery is that, the dexamethasone has some effect, tocilizumab has some effect, but it's a population-based study, and stratification and personalization are clearly the next steps to make sure we give the right treatment to the right patients.
Jennifer had a couple of questions related, one of which you've answered. So what do we know about the possibility that the ILD present in post-COVID patients will be progressive? But she's also asking about the hypothesis of reversibility of post-COVID fibrosis.
I think the inflammation is clearly resolvable. I think the fibrosis we're less certain about. Even if you look at post-ARDS, if there's sort of real fibrosis as opposed to what some people are reporting as fibrosis, now, the radiologists have some dispute over what should be called fibrosis after an acute event like this. So if there's evidence of traction and honeycombing, that tends not to resolve. And I think most people would be content to see a stable fibrosis. That would be regarded as a win. But if the atalaxis and stuff, that I think that is more likely to functionally resolve, even if it stays on CT scan. And I don't think people would really consider that as fibrosis as we know it.
Okay, next one from Francesco. Do you think that MUC5B minor allele could be protective from severe COVID disease, since carriers of this will develop less inflammation in the acute phase?
So I think that's a great hypothesis, and certainly the sort of, when you look at any genetic defect, there's always there's normally a survival benefit if it presents with disease in later life, and that was the sort of David Schwartz's original hypothesis, that this offers protection from infection in early life. So I think it's a very good hypothesis. That the only concern we have is there's a lot of selection bias in terms of who people with fibrosis shielded in large parts of the world. And so there is that inherent selection bias in the studies. But that wouldn't explain why MUC5B and all other genes had a different response. So MUC5B is less severe than the other genes, but if selection bias is at play, what that does is it just moves everything towards the protective effect. So if you remove that selection bias, MUC5B may have a little effect, positive or negative, but the other genes would have a much worse effect. So we don't know whether there is selection bias or whether the MUC5B gene is really affecting pathophysiology at this point.
Okay, next one from Sinead for Cillian. Are there plans to upskill and educate our community care, GPs, etc., to assist with management of non-hospitalized patients?
Good, yeah, I believe so. I believe within Ireland there is a developing program, which will be surrounded really based on the chronic care model that's already there for asthma and for heart failure. That will be rolled out within community hubs. And I think that will involve physiotherapy, occupational therapy, and other allied health professionals in conjunction with their general practitioner. And obviously then there'll need to be a route into specialist care then in the hospital if needed for persistent symptoms, and also access to diagnostics. So yes, there is, we'd like to see it happening soon as well. I think now is the time really to get started in terms of, like, really had our biggest wave in January compared to last March. So really the bulk of patients now are coming to us and back to our clinics, and now is the time to get started, I think.
And there's a very related one from the chat from Elaine. I think it's answered. So do you envisage this falls within the remit of primary care, or did your suggested model also work more closely with rehab, acute, allied health professionals?
Yeah, it's both really. I mean, obviously in Ireland, your general practitioner is, you know, and in the UK, your general practitioner is the person who, you know, who orchestrates your healthcare, and everything should be, you know, going back to the general practitioner. So particularly for patients who had infection in the community and stayed in the community, I think that is going to be worked with the GP and also with allied health professionals that are associated in the community. But that really needs to be, I think, supplemented a lot, because we don't want to take away from all those the good work that those allied health care professionals are doing with chronic disease such as COPD and interstitial lung disease already. So that needs to be further funded, so that those patients can take care of those healthcare professionals can take care of their existing patients and the new patients that are coming on stream.
Thanks, Cillian. So just one that's in the chat that's answered, but just to go through it for the video. So from Paul, given risk factors for severe acute disease is obesity, and these patients have most post-COVID lung disease, what does this tell us about the fundamental mechanistic role of fat cells in the disease in terms of the acute pulmonary disease and chronic sequelae? Yeah, it's kind of a fascinating area, and we've definitely noticed obesity is definitely, you know, one of the highest risk factors along with age. But again, but even with morbid obesity in particular, and those patients that are going to intensive care, the majority of the younger patients are obese. I think there's probably two different factors at play here. Firstly, obese patients may be more difficult to ventilate and develop respiratory failure a little easier, and also develop like a CO2 retention or a type 2 respiratory failure more likely. And that's what we saw definitely with our patients on the ward. More difficult to manage with non-invasive ventilation, and then more of those patients require mechanical ventilation. But there are a lot of theories around the influence of obesity in terms of the inflammatory response, and, you know, fat cells. I think basically the question really is well placed. The fat cells can be involved in the inflammatory response as well, and also they can release inflammation such as IL-6 and TNF-alpha and other cytokines and chemokines that are involved in play in the pneumonitis that we see in COVID-19. So really, from two different angles, patients with obesity are at increased risk of severe disease. It's an interesting topic, and I think it may shed light on all sorts of diseases that are associated with obesity. As COVID is telling us a lot about other diseases, including ARDS. We're learning so much about that right now because the numbers are huge, and the research studies, like Gisli has described, are ongoing. So I think we will learn a lot about obesity, ARDS, and other infectious diseases from this COVID-19 pandemic. Question from Nicola Cassidy from the Irish Lung Fibrosis Association. So ideally, how often should post-COVID-19 patients have CT scans, pulmonary function tests, and 6-minute walk tests? Will there be rapid access clinics established for post-COVID-19 patients who subsequently develop dyspnea?
Yeah, I mean, that's a great question. I think, you know, there isn't really a standard answer for every patient. I think that the care and the investigations need to be tailored for the patient. So patients who are in intensive care, certainly, and those that were non-invasive on non-invasive ventilation should have quite a comprehensive assessment at the 12-week point, I think. And that may include Radiology may include CT scans, pulmonary function tests, and definitely a functional marker. I think the 6-minute walk test is really an excellent test in terms of the global functioning of the patients. For patients in the community, it's less clear. I think that would largely be guided by what level of symptoms are persistent. And I mentioned earlier, really about safety netting, just to make sure that for patients immediately post-COVID, not having a pulmonary embolism. I think that's one of the things we need to really think about hard and not miss, and have a low barrier to re-refer to the hospital or to emergency for that. In the longer term, I think patients should, really should have some functional assessment like a 6-minute walk test in the community, and that can be done quite easily with physiotherapy. And many patients, I think, that may work for, and pulmonary function tests also can be done with their general practitioner. So again, it kind of depends on the level of severity initially, and then tailoring the investigations to the patient. So I wouldn't have an overall interval for testing for every patient.
Gisli, do you want to take this one from Lee? Should we be looking at measuring membrane diffusion in long COVID to assess if remodeling or shunting has occurred?
I think we should, for sure. I think it's difficult because it's a more complex test than spirometry. But as the data show, there are lots of people with reduced diffusion. I think, as Cillian said, you might want to target it a bit. For example, if a test such as the 6-minute walk test is normal, or what we're doing in the community is sit-stand test, 1-minute sit-stand test, because it's like a 6-minute walk test but easier, quicker to perform. If that's normal, then you might not worry so much about the diffusion, but certainly if that's abnormal, then I think referral for assessment, which ideally should include some assessment of diffusion, should occur.
Question from Ian: how helpful is the term long COVID? It implies a direct pathogenic role for the virus, which we have not established. The highest rates occur in patients with unconfirmed illness in spring 20.
I think that's a question for the person who invented the term long COVID, which wasn't me. I share some of Ian's sort of skepticism about the term, but there's many terms that we're not happy with but have to use.
Yeah, it's a difficult term. It's more a social media term than a diagnosis. I think it's a collection of symptoms. It's a syndrome until we really have a diagnosis. So I think, it's yet to be defined properly.
All in agreement with Ian. Question from Jennifer Wesco from the Wesco Foundation for Pulmonary Fibrosis. Do you see the number of lung transplants increase as a result of COVID-19? Second point, what do you see for education and support for patients and families coping with the repercussions of the disease? And what do you see in movements forward to do so?
I mean, to the point about transplant, I think it's really difficult to say. I think we're so early in this pandemic and the response, and as Gisli was saying earlier, fibrosis is really not going to present for probably a number of years. So maybe down the road we're looking at that, but it's really too early to do that. I think in terms of education and for families and patients, that I think is really referring to post-COVID syndrome, I guess. And I think there is a lot of literature out there. The NIH or the NHS has developed a lot of literature in Ireland. The Department of Health has developed a lot of literature as well for patients. So I think there is quite a bit out there for patients and their families. But of course, there can always be better information as well.
One that touches on something we've already discussed, but maybe there's a different point to it. Do you think there are any key symptoms that would indicate that a patient would need to return to hospital? And what would count as failing a 6-minute walk test or 1-minute sit-to-stand test?
I think severe shortness of breath or severe chest pain are they're absolutes that you really need to go back to the hospital. And again, that's really back to not wanting missing something like a pulmonary embolism. To remember as well that there's a lot more going on with patients, and patients can have more than one disease, so they can also have cardiac disease. So I think, and we can see that quite a lot of patients, like the one that we just looked at, had cardiac disease and had a right coronary artery disease as well that needed stenting. So I think we want to try not to have blinkers about just looking at a patient and saying this is just post-COVID syndrome. We need to think about what else might be happening with that patient. And I forgot, was there a second part of that question, Eammon?
What would count as failing the 6-minute walk test or 1-minute sit to stand?
I don't really would say failing. I guess, having less than 80% performance probably. I think what we're looking out for on a 6-minute walk test is really not achieving a significant distance for your age, and also having a desaturation. I think those are the important things. Having a desaturation less than 88% is really significant, and even having desaturation less than 94% in a younger person is probably significant too. Really looking at the data, I think there was a question about that. There wasn't, at 1 year, we didn't see desaturations in that population. Now, it did exclude some patients who were too unwell and were on oxygen to do the 6-minute walk test, including the patient that I discussed, and another patient that had COPD, pre-existing COPD, but certainly desaturation, not achieving an adequate walk distance. And also, the interesting thing there was the resting heart rate. Resting heart rates can really mean a number of different things. The thing we think of most commonly is deconditioning. So the patient is really unfit, and that can happen because they've been in bed or they've been in hospital for a long time, and also when they've been cocooning at home after their infection, they haven't been doing their exercise that they would usually do, so heart rates can be high. The thing that we worry about is myocarditis. Now, we haven't seen as much as been quoted in the literature. I think there's been some papers that have shown really high rates, but our experience is that this is quite a rare sequelae, but we have seen a number of cases that are concerning, and a high heart rate at rest or in response to exercise is something that needs to be investigated.
Yeah, because this, I think, answers Paul's question.
Yeah.
Can you advise the degree of desaturation in the cohorts when undertaking 6-minute walk test post-COVID? I don't think you presented this.
Yeah, it was there, but it didn't seem to be in that cohort with those provisos that we excluded some patients, but didn't see a great deal of desaturation, at least.
You mentioned about diagnosing asthma. So Johanna has a question. Is there a physiological link between post-COVID syndrome and newly diagnosed asthma?
It's a great question. I don't know. I mean, when you think about, like, probably 10 or 15% of the population have asthma or have wheeze at some time in their life. So it's such a common disease. And we often see wheezing post-viral infections. So wheezing doesn't mean asthma on its own, but it can be a part of a bigger diagnosis. So I think we are diagnosing people that had pre-existing asthma or mild asthma, now having some bronchoconstriction after their viral infection, which I think is probably going to be one of the most common respiratory consequences of COVID, because asthma is just so common. But it needs treatment, and it needs assessment, and assessment first, and treatment, obviously, and that can be done largely in the community.
Another question from Paul. What evidence is emerging regarding the incidence of pulmonary vascular disease as a post-COVID phenomenon, not just related to thrombosis and potential CTEPH, but pulmonary arterial hypertension also?
We don't know the answer to that at the moment, Paul. That's a great question, and again, I think the reduction in gas transfer at 3 months, 6 months, and emerging at 12 months suggests that there is something there. The Xenon MRI, which we will be doing as part of the post-COVID study, will give us some hints, but it's something we're very interested in. And the Pulmonary Hypertension Working Group, which is chaired by Luke Howard and Mark Toshner as part of post-COVID, post-COVID, sorry, will hopefully give us some answers on that fairly soon.
Yeah, it's a really interesting topic. I think there's, at least at a theoretical level, we know that the endothelial cells have ACE receptors, so they are infected by the virus. So and certainly the level of complications with coagulopathies and also with PE, pulmonary emboli in the ICU and in the admitted patients really suggests that's a huge part of the pathology going on.
Question from Matt: has there been any research on the effects of vaccines on patients with long COVID?
Not that I'm aware of.
I'm not. I haven't seen anything published. I've just heard some anecdotal information about that, but nothing that's been in print or preprint.
Question from Elaine: have you had any experience to date with airway stenosis post ICU in COVID patients? If so, what suggestions would you have to monitor and intervene for same?
We haven't, and you know, it may be a little surprising, but I think usually you would see that with prolonged intubation, but I think that's with better techniques in terms of intubation and monitoring tubes. I think that's a less common complication of prolonged intubation. But again, maybe it's a little early, you know, maybe we have to wait some time to see that kind of a complication, but certainly in our cohort here and talking to colleagues in other ICUs across Ireland and the UK, I haven't heard of it or seen it.
So we've talked about the 6-minute walk test and the sit stand. So one question: due to the widespread sequelae of infection, what are concerns about taking patients on for exercise? What would you consider a red flag contraindication to exercise? And it says, as you pointed out, Cillian, you know, high resting heart rate, maybe just a deconditioning.
I think there aren't many, you know, contraindications. I think taking on early rehabilitation is a good idea, but I think that needs to be in the setting of having had an assessment by your general practitioner, and also an assessment, you know, when exercise is monitored by a healthcare professional. I think that's absolutely safe.
What sort of numbers in your post-COVID clinic present with vestibular difficulties?
It's a small number. I would probably say less than 5%, but certainly it is. I've seen a number of people with that. It's not clear what the cause for that is. Neurological deficits and psychological and psychiatric consequences are common. I think there was a recent paper looked at over 250,000 people, I think across the UK, which showed it probably a 20 to 30% of people with complications. But vestibular problems, I'm not sure that I really understand the pathogenesis of that, but certainly we see patients with it, but it seems to be self-limiting, and I haven't seen any at 1 year.
Question from Clarifil: is post-COVID pulmonary rehab necessary to all patients who received non-invasive ventilation or high-flow nasal oxygen?
I would never say always in these kind of situations. So I would say if a patient still has symptoms, I think then they need some form of rehabilitation, yes, but not for everybody. No, we've had actually our experiences that most people post-COVID do really well. And you know, while I show the worst case scenario of someone who spent many months in rehabilitation, the vast majority of people do really well after COVID-19, and particularly young people do well. So not everyone needs rehabilitation, but certainly it needs to be available to those that need it.
This is an Irish specific one, so probably for you, Cillian, from Sinead. I know a lot of post-COVID physio colleagues are very worried about adequate access to appropriate diagnostics. If no local post-COVID-19 clinic, Dublin is well served, but not others.
Yes, I think that's coming. I'm not involved at the national level with that, but some colleagues are. And it seems there is plans to fund a national service that with a number of different hubs across the country. So I think that is coming, but I completely agree. It needs to be funded in a significant way, so that diagnostics are not left out of it, and also access to diagnostics, because while in the hospital we can get diagnostics, for GPs it's a little more difficult in Ireland, and then that's not the way it should be. And I hope that that will be addressed through a program that's going to come on, I hope, very soon.
I think we've got to most questions because Gisli has to jump on a Boris bike and head on a train shortly. There's one: is continuous screening for a week or more using wearable medical devices helps to identify severity of COVID-induced ILD? I don't know who wants to take that one.
Colin, isn't it?
Are you muted, Colin?
So Eammon and I are in the same room, so if one of us doesn't mute, you get an echo.
Yeah.
I think I'm not sure about wearables, except the simplest wearable is, you know, your watch or the phone itself at least will give you some activity data. But certainly I think there is merit in, for some people, or maybe as part of structured research or a structured care program, in tracking some measures of activity or measures of health. It might be some patients may need to be, you know, keeping an eye on pulse oximetry for a while, which will include some heart rate data. It might be some people may need to keep an eye on blood pressure for a while. But I think there is some merit in trying, I've always had the view you should try and capture some data on symptoms, something objective, and perhaps occasionally some quality of life or scale that's designed to quantify difficult to quantify symptoms such as fatigue, for example. So I think there is some merit. It's interesting. We've been running an acute COVID monitoring program in Ireland. We've been involved in that since the onset of COVID last year. There's about 2,500 patients have been through this. But Mount Sinai are using our system for their acute COVID patients, and they've chosen to monitor their patients for up to 90 days after they come to hospital, whereas in average in the Irish setting, patients are monitored for about 14 days, literally just for the fairly acute phase. And I think it'll be interesting. In fact, they actually have a poster at ATS on presenting some of that data, but I think it'll be interesting to see the outcome of, you know, measuring pulse ox and some symptoms for a longer time. And maybe most of those patients probably have no symptoms after 30 days or so, you know, because there's a whole variety of age groups in their cohort. But yes, I think it's worth doing. I think the difficulty is to identify what is the symptom that matters for that patient. For one person, it's fatigue. For another person, it's going to be breathlessness that they're not used to, or unaccustomed breathlessness with normal activity. For another person, it'll be something else. And I think it's understanding that, then tracking it over time, and perhaps marrying it to, I think the big question is for any person is, can I get back to work without feeling exhausted at the end of the day? You know, can I get back to what I usually do? That's the other key question. That can be, you know, the time to follow up to achieve that endpoint is probably fairly diagnostic of how bad they are.
Thanks, Colin. I think we have everything answered. So thanks to everyone for joining us today. A big thanks to Gisli and Cillian for sharing their insights with us. If you have any more questions or would like to find out more about patientMpower, please send us an email, info@patientMpower.com. Today's webinar was recorded and the link will be shared with you all in the coming days. So thanks very much again and enjoy the rest of your day.
Thank you. Take care.
Bye.
Bye.